molars muscle or meibomian gland region. So the thing is the infection is occurred at the center of the orbital septum. So we say preseptal cellulitis. This is the main happen at the inflammation, or it may be occurred at the secondary to the injury to the eye. Okay, this is preseptal cellulitis. This is the one of the condition occur region. Okay, eyelid and orbital regions. Eyelid region, orbital septum. Okay, so the main thing in here is edema, swelling, going to be very. The main symptoms are here is pain and redness and heavy watering. So these are the main happening at the preseptal cellulitis. So it is mainly occurred at the around the globe, around the eyeball. Okay, and here this is the orbital cellulitis. Orbital cellulitis means it is mainly occurred at the zygomatic region area. Okay, so it is mainly occurred at the because of sinusitis mainly happened. Here we have sinus here we have. So when the sinus is infected, then it will be also passing at the orbital region and this orbital fatty cavity here. So these cavities will be inflamed with the bacterial or viral or due to the secondary to the injuries. Okay, so this is called orbital cellulitis. And coming to the congenital eye disorders, here few of them are mainly ablepharon. Ablepharon means they don't have eyelashes, eyebrows. Okay, eyelids are absent. Only skin is available here. So this is the looking, and it is very rare condition. Okay, so there is no protection of the eyelashes or eyebrows from the external environment. Okay, this is the condition is called ablepharon. Means A means absent, blepharon means eyelid condition. Okay, next is congenital coloboma of eyelid. We already discussed that the genetical diseases or disorders at the condition. So this is the incomplete closure of the upper eyelid. We say congenital coloboma of eyelid. And next condition is ankyloblepharon. Here, this is the upper lid, this is the lower lid. But here, what will happen at the congenital or at the age of the initially, what will happen? The fusion is occurred at the lid margin, upper lid to the lower lid margin. Okay. And again, it is the congenital ectropion. So congenital ectropion means the eyelid is emitting outside of the environment. Okay, and congenital entropion. So the lower lid will be inverting inside. So the eyelashes will be rubbing against the cornea and sclera. So this may cause corneal scar or corneal irritation, watering, photophobia, and all the symptoms will be occurred at the time of congenital entropion. And next is epicanthus. Epicanthus is the this is the external fold. It may be occurred due to the incomplete closure of the eyelashes and nose will be happen, and it is mainly uh, what is that? Mainly observing this epicanthal fold and the flat nose bridge. They have because of this epicanthal fold covering half of the here we have caruncle is there. this caruncle will be closed because of this epicanthal fold. And next is BPS syndrome. We say blepharophimosis. Here, what will happen? This is the two conditions are involved here. One is ptosis and reverse epicanthus. Here, the epicanthal fold is covering upper to the superior to the inferior, but here reversely it will be closing. Okay, so inverse epicanthus inverse here and also ptosis. We say this is the condition is called blepharophimosis. Okay, and next is related of lacrimal drainage system. So here you all need to know the normal structures of the lacrimal apparatus. Here we have lower puncta, here upper puncta, and then we have vertical canaliculae, and then we have horizontal canaliculae. This is the horizontal canaliculae. This horizontal canaliculae and superior vertical canaliculae are connecting here. We call this region is common canaliculae. Then this is a lacrimal sac. So this is the lacrimal sac and this is the NLD nasolacrimal duct region, and here inferior meatus. So this is the inferior meatus. So what will happen? We have two eyes. This is the supratemporal region, means not superior, not temporal. This is the in between the superior and temporal. So we say supratemporal region. Here we have lacrimal gland. This lacrimal gland will be releasing lacrimal, tear film. This is opening at the, so these are which are passing into the eye in between water pulses and even their vested eyes have larynx. These are eyelid margin. Like when we are making, that time these lacrimal openings are pouring that so the drainage, the used tear is drainaging through the inferior puncta and superior puncta. This will be going and passing through the canaliculus and common canaliculus, lacrimal sac, then nasolacrimal duct. Then it will be going into the throat through the few problems are occurred at the that region and the passing line. So that is called atresia of the lacrimal puncta canaliculae. So here what will happen when there is a growth of our what is it called? At embryogenesis stage, what will happen? This puncta, and this region will be closed itself, and that canalization, that canal, that opening, and that passing pathway is not fully developed. So we say atresia of the lacrimal puncta or caliculae. So what we have to do is we need to do syringing test. Syringing means a small needle will be there, separate needle for lacrimal syringing. So when we hear that opening will be here, so we take that syringe and filling with saline and we pushing through this cavity, then that will be going inside the nasolacrimal duct and through the inferior meatus, and that saline water will be going inside the throat. If the patient will be answering that that water is going inside, then we know that puncta passage will be clear. If that water or that saline water is not passing and coming through the same puncta or coming to the opposite puncta, we say regurgitation through the same puncta or regurgitation to the opposite puncta. So there will be a blockage here or maybe blockage here. So the passing water will be coming back or coming out from the superior puncta. So this is all happened because of atresia of the lacrimal puncta or canaliculum. Nothing but that failure or closing of that canalization. So this is the one condition happened at the lacrimal obstruction blockage. Okay, and the next is congenital lacrimal fistula. It is the so here what we have superior this common canaliculus is nose, but it coming out area. So this spot is called congenital lacrimal fistula. So that common canaliculus is coming out and it is this is congenital lacrimal fistula. And next is dacryocystosis. This is the this region is swelling due to the infection or blockage or at the nasolacrimal duct region. So here what we have due to because of that blockage of the nasolacrimal duct. Okay, this is the one type of condition we say dacryocystosis. Here it is epiphora. This is the one type of condition, and the externally. So excessive watering will be there. We say condition epiphora. So this is all because of nasolacrimal duct obstruction. So that is the lacrimal drainage system. And coming to the cornea, we already know and we discussed previously in the will be small and the cornea also will be small. And next condition is anophthalmos. Here the globe will be absent. So this is anophthalmos. An means no or absent. Ophthalmos means related to the eyeball. So this eyeball will be absent in the patients. We say anophthalmos. And next is nano-ophthalmos. Nano-ophthalmos means nano means normal eyeball will be the axial length will be 22 to 24 mm. So this will be less than 24 or 22. So here we have diopters. Here is the eyeball will be less diopters. Sorry, high degree of hypermetropia will be there compared with the because of that eyeball will be the rays will be falling behind the retina in the non-ophthalmos patients. Okay, and the anterior chamber will be very shallow in the non-ophthalmos patients. Okay, see here the eyeball will be large and here the eyeball will be small. So this is the one type of condition we say non-ophthalmos. And next is megalocornea. Megalo means enlargement of the cornea. So this is the megalocornea. This is the microcornea. See here microcornea or microphthalmos. So these are the conditions will be at a time visible in the embryogenic patients who are not fully developed or premature babies. So this is all happen in the examination room at the corneal level. And coming to the anterior chamber and cornea. So here keratoglobus. See here the cornea will be looking like a globe. Okay. So it is also autosomal recessive condition. So it is not inflammatory, and we need to check for topography because of we need to check for thickness of the central cornea because of we have 5 layers. So those 5 layers will be strengthening. We need to check for strengthening of the cornea. Okay, in the keratoglobus patients. And next is keratoconus. So here the eyeball is the cornea is looking like a globe-like structure, and here keratoconus means the cornea will be like a total opacification of the cornea and sclera, and it is the so not fully developed due to the prematurity of the babies. Most oftenly we have seen in the premature babies, and genetically we have family history of corneal corneal coloboma or corneal abnormalities. These are the main common conditions. Sclerocornea will be happening in the premature babies. And next is infantile glaucoma. So this is the difference between normal. This is the see here it is megalocornea and the eye looking like a bluish and what is that called? Enlarged cornea will be there, and opaque cornea will be not transparent. So the cornea will be very opaque in the patients of congenital or infantile glaucoma. So you need to observe each and every time. So here the eyeball looking black, and here it will be looking different. So we need to check for second time, or we need to refer to the ophthalmologist for immediate. When you observed at the examination room or at the delivery point or at the uh, small neonatal care unit, so we need to do is first of all observe the cornea is cloudy or the normal cornea. The cornea is normal in size or abnormal in size. The cornea glow will be, or cornea or iris is visible or not. So you all need to know the examination time at the examination room. Next is intestinal pupillary membrane. So here what will happen is the it is also developmental delay or abnormality of the iris at the embryogenic stage. So here the iris pigment will be coming out or coming back of the iris. So what will happen? This pigment will be, if coming out means what will happen? This small pigments will be going at the uh, what is that called? Angle of the anterior chamber. This may secondary to the cause glaucoma in some other causes. If this pigment is going back to the iris, that there will be a lens will be there. That lens will be attaching to this pigment, and that lens will be going to be opaque, or it may causes cataract also. And next is iris abnormalities. These are all iris abnormalities. Here we see iris coloboma or iris hypoplasia. Iris hypoplasia means irregularity of the iris. So, and it will be going somewhere or absent of the iris tissue. We, here it is iris coloboma. This is Aniridia means no, and means no, means iridia. So here no iris is visible here. Okay. And next is congenital iris ectropion. So what will happen is the this iris will be day by day, it will be going back to the pigment. So this will be going back to the pigment. So we say this is congenital iris ectropion. It is mainly also causing, this is the secondary to the glaucoma, because of this pigment will be floating in the anterior chamber, and it will be going at the angle of the anterior chamber. So there will be a filter. This one, lens canal and trabecular meshwork, and we have five structures are there. So the main thing is the trabecular meshwork that will be filtering this iris pigments, and it may cause secondary to the glaucoma. Okay, see here secondary to the congenital glaucoma. And next is dysphoria. So dysphoria is a abnormal shape of the pupil. See here the pupil will be shaping like center of the iris, but here it will be looking like different, and here also different, and it will be moving, and here multiple people also there. So this is the dysphoria, abnormal shape of the eye. It is mainly occurred due to Axenfeld-Rieger syndrome. So and also some patients with the ectopia lentis. So these are the main conditions associated with this dysphoria. And next is congenital meiosis. And a few people, we have 3 mm of normal people. 3 to 4 mm is the normal people size of our normal human being. But coming to the congenital meiosis, these people have the pupil size will be very small compared with to the normal. So it will be always meiosis means it will be not dilating always. It will be constricting compared with to the normal eye. Okay. So mostly it will be increasing its size like 2 mm only. Okay. And next is congenital mydriasis. So here it is a normal people. We have 3 mm of 3 to 4 mm size of the people have, but in this people it is mainly mydriasis. So it is occurred due to the injury at the delivery time, or any neurological condition, or any relate to that eye power. So what we can is the eye people that muscle is when constricting muscle is not working. In that time, what will happen? This pupil size will be dilated and fixed. Correctopia is displacement of the pupil, so it will be displacing from the this central part up to the some other side. Okay. So this is the mainly it will be this correctopia is forming to the nasal side of the okay, nasal side of the eyeball. So these are the most of the conditions we all need to know what is correctopia, congenital mydriasis, how congenital myiasis is looking like, and what is the dysphoria, and congenital iris ectropion. So these are all the initial daily we have seen in the clinic in RBSA or iris or orbital problems, pupillary pigment, and these are the congenital developmental delayed pediatric session problems are uh, daily seen in the clinics. Okay, this is the congenital glaucoma. So you all need to know what are the types of diseases, and some other normal like congenital, I mean conjunctival inflammation, stye, challenge, and you all know those are all the problems. But you all need to know these uh, abnormal conditions like what is an anophthalmos, what is an if there is an excessive distance between the two orbits, we say teleorbital problem, telecanthal problem. So these are the identification. It should be from your end. You all need to know. Okay. So these are the problems we discussed, and tomorrow onwards, in the next class we have discussed what are the steps we need to check for uh, examination of the children. Okay, so pediatric examination at the level of the examination room. So in the next class we will discuss later. So how the examination should be, whom should be happen, and what are the steps we need to ask to the patient, and what are the information we need to gather for the patients, and what are the conditions we need to check for babies, and then we go for a pediatric after birth age and infantile checkup and preschool children checkup and school aged checkup. So we will discuss later in the next class. Okay. So is this regarding today's class? So I will share this PPT with you. You all need to go through these slides. What are the conditions? Hyper. So these are all things. So any doubts? Hello. Class one. Huh? Ah, yeah. Huh? ఇది చెప్పేసా ఏంటి ఇన్స్టాగ్రామ్ టెలిగ్రామ్ అంతా సరే వేసారు. ఆ?